Good evening, ladies and gentlemen. I would warmly welcome you all to our exciting webinar this evening, focusing on a truly important and challenging topic, adolescent gynecology. My name is Amr Nabil Badawi. I am a consultant obstetrics and gynecology, researcher at National Research Center in Egypt, and a board member of the Egyptian Representative Committee of the RCOG. So this webinar is number 22 that's organized by the Egyptian Representative Committee of the RCOG. This evening, we navigate the unique challenges of adolescent gynecology, a particularly sensitive and multidimensional field where clinical management intersects with ethics, communication, and cultural awareness. I would like to express my deep appreciation to our esteemed speakers for tonight, Professor Yasser Abu Talib, Professor Rasha Hamza, Dr. Muhammad Hassan, and Dr. Hala Damanhouri for their time, effort, and dedication. Our webinar tonight comprises of 4 sessions tackling 3 important topics: precocious puberty, intersex condition, and female genital mutilation. Each session will take approximately 20 minutes, followed by 5 minutes for discussion. So please feel free to submit your questions using the Q&A button at the bottom of the screen, and we will do our best to answer your questions in the discussion time. So before we begin, it gives me a great pleasure to welcome a truly inspiring figure in our field, Professor Yasser Abu Talib. He is the chair of the Egyptian Representative Committee of the RCOG, a professor of obstetrics and gynecology at Ain Shams University, professor of obstetrics and gynecology at Army College of Medicine, and a certified trainer in many esteemed societies and organizations. It really gives me a great pleasure to welcome him and to have him open our webinar tonight with a few welcome words. Thank you, Professor Yasser. Please start.
Okay, so hi, how are you doing? I hope that everything is all right. It's a great pleasure for me just to meet you again in our 22nd webinar that we used to do every 1 to 2 months. Our aim is just to have a strong bond all over the world and exchange ideas and exchange knowledge all over the world, sharing with you everything in our field of obstetrics and gynecology. It's actually our pleasure as members and fellows of the Royal College to invite you all for this webinar. Just before start, I would like just to thank very much, to start with Dr. Amr Nabil, who is used to be a very active member of the committee of the Royal College, doing his best to introduce us and support us, especially in the field of electronics webinars, and support us every time. So thank you very much, Amr. It's my pleasure actually to work with you. And to start with, I would like just to thank very much speakers today. Dr. Rasha, thank you very much to accept our invitation to discuss a very important subject, which is precocious puberty. To be honest, me, myself, still, I want to know more about this problem because it's a very big problem, socially wise and economic wise, and as well medical wise. So it's our great pleasure actually to be from outside of our specialty, but specialized in this field to address us regarding to this critical subject. As well, it's a great pleasure to introduce my colleague and my friend for a long time, Dr. Hala El-Damanhouri. She's well known for everyone with lots and lots of researches back in England and Saudi Arabia. So thank you very much to accept our invitation. And to clarify just one thing, I'm going to discuss the female genital mutilation from the medical side. Meanwhile, Hala is going to address this problem worldwide and how to antagonize the medicalization of this problem and how common it's there, because it's considered as tradition in many countries. You will surprise what we are going to tell. But just one of the greatest thing that I would like to thank him all the time is the treasurer of the our committee, Dr. Muhammad Hassan, and he's my dear friend and colleague as well, because we used to work together and sort out the problems 24/7. So thank you, Muhammad, very much to have this complicated subject. To be honest, me myself, I am a little bit have a sort of a little knowledge regarding to intersex. And I remember well when I was a student and come to the intersex chapter, I used it just to stop going through it because it's markedly complicated. But I know you are tackled this problem in a very proper manner because you are talented to that. So thank you very much. Thank you all for participating our webinar, and I'm dead sure that it will be a successful one as usual. Just let me to have the second slide, please. I would like just to have an announcement regarding to two things. First of all, it's a great pleasure to invite you to our 13th annual conference, which will be held in September during the period between 23rd and the 25th of June this year. And it will be in Triumph Luxury Hotel. Definitely, this will be a great congress because we are inviting people from all over the world, mainly from England, and we are tackling new subjects such as robotic surgery, as we are inviting specialized persons doing a marvelous job using robotic surgery, including uterine transplantation. Our colleague from India is going to address this subject, and it will be a surprise to everyone what we are going to tackle during this conference. So waiting for all of you to participate in this conference. And as usual, around this conference, we used to conduct many workshops. Next slide, please. As you know that the International Representative Committee of the Royal College and the Society of the Royal College, we used to conduct many courses, but the most important thing that these courses are hands-on. This is the point. So it's not just to discuss it through the internet or to give session only, but it's hands-on because our objective is to raise the standards of practice all over the world. So this is a list of the meetings and the activity that we are going to do around the Congress. Let's go just quickly through it. So one of the most important and the new one, which is unique one, is the gynecological oncology and colposcopy. It will be between the 3rd and 5th of May. It's hands-on oncological operation and use of colposcopy. You are going to put your hand and to manage the situation, and you will have a great experience for that. This is one new one. TLH, as usual. CTG, physiological one. One of the most important one as well, as we do colposcopy, it's another one between 7th and 8th of July. It's hysteroscopy. It will be 2 days, one for basics, and the second one for operative intervention, hands-on, in Ahmed Maher Hospital. This is a unique one. Pelvic floor, as usual, I think everyone all over the world know that 3 days practice hands-on, pelvic floor, urogynecology, and pelvic floor prolapses, vaginal hysterectomy, sacrospinal fixation, and blah, 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 blah. Robust RCOG, basic practical skills, and we are preparing now two or three courses which are unique. It's one, abnormal uterine bleeding using Mirena coil hysteroscopy and colposcopy as well. It will be hands-on in the form of stations. And the most new one, it's artificial intelligence, because artificial intelligence is very important in the field of obstetrics and gynecology. So we are preparing now a course, and I think it will be great to use artificial intelligence in this field, use its basic practice. And again, it will be a great pleasure to see you all during my annual conference next September. Thank you very much to give me the chance to have this presentation, and may I ask Dr. Amr to, I will hand over the Congress to this meeting to Dr. Amr to start the Congress. So thank you very much, and see you soon during my presentation, FGM. Thank you.
Thank you so much, my dear Professor Yasser, for your very kind words. Now moving on to our first speaker, Professor Rasha Hamza. She is the head of pediatric endocrinology and obesity unit at Ain Shams University, chair of the Education and Training Committee of the European Society for Pediatric Endocrinology, the vice president of the Arab Society of Pediatric Endocrinology and Diabetes, and she's also an editorial board member for several prestigious journals, such as Journal of Pediatric Endocrinology and Metabolism and Pediatric Diabetes. Thank you very much, Professor Rasha, for being with us today and sharing this very important topic, precocious puberty debates and updates.
Good evening, ladies and gentlemen. Thank you very much, Dr. Amr, for the very kind introduction. And before starting, I'd like to thank Professor Yasser Abu Talib and Dr. Amr for the very kind invitation. It's really a great pleasure being with you in this esteemed webinar. And as Professor Yasser mentioned, I'm not an obstetrician nor a gynecologist. I'm a pediatric endocrinologist, but it's really a pleasure being with all of you, because there is a lot of areas of overlap between gynecology and endocrinology. And one of these areas is the topic that I'm going to discuss today, which is precocious puberty. My screen is shared, I think. Okay, so I'm going to discuss some debates and updates and a lot of gray zones in this really sensitive topic. And let me open the scene by showing you some screenshots of the cases that I'm going to share with you, the real life case scenarios, showing you that there are various modes of presentation of precocious puberty. And of course, it's a very common scenario nowadays. Precocious puberty is becoming very common. And this is a scenario of a worried parent coming with a child with precocious puberty, having a lot of questions in mind. And when facing a girl with precocious puberty, the frequently asked questions that we face are, does my child have precocious puberty? Will it affect the final height of the child? Could it be hiding a serious medical illness? And finally, and most important, does she need treatment or not? And looking at the spectrum of puberty, we have the two extremes of precocious or delayed puberty, with the normal range lying in between. But even more challenging and difficult to manage is the early but not precocious puberty, the late but not delayed puberty. And indeed, there are population differences in the pubertal status, and therefore there are emerging differences in the definition. We as Arabs have different ages of onset of puberty compared to USA and Europe. And this is an interesting study published in 2020 showing various ages of onset of puberty across the continents. And you can see that in the Middle East, where we are, the age of onset of puberty is getting earlier, 9.7 to 10.3 years, which is totally different from what occurred 20 or 30 years ago. And the age at pubertal onset based on philarchy decreased 3 months per decade. And this is applicable worldwide from 1977 until 2013. And this is a research that I was honored to lead that showed pubertal onset across 17 Arab countries. And to the best of our knowledge, this is the first data on puberty in Arab countries. And what we found is that the mean onset of the start of a breast bud among Arab girls is 10.5 years, which is getting again earlier and earlier. So you can see that the onset of puberty is affected by a lot of factors like genetics, of course, nutrition and body fat, the general health, exercise, climate, geography, and psychological appearance. But who presses the start button of puberty? Kisspeptin triggers the onset of puberty by stimulating the GnRH production. And looking more in depth, how does this happen? We all know this is the hypothalamo-pituitary gonadal axis. Prior to the onset of puberty, there is a central neuronal inhibition which suppresses the hypothalamo-pituitary gonadal axis. And the sex steroids exert a feedback suppression on the hypothalamus and pituitary. And the hypothalamic gonadostat and pituitary at this point are very sensitive to the negative feedback from the steroids. With the onset of puberty, sensitivity of hypothalamus and pituitary to the suppression of the axis decreases gradually, and the central neuronal inhibition is removed. And then the hypothalamus and pituitary start operating, stimulating GnRH, FSH, LH, leading to activation of the axis. So this is the normal physiology. And it's not only the kisspeptin. There are a lot of neurons like the KINDY neurons, which act on the GnRH stimulating pulsatile release of GnRH stimulating puberty. A very important question was raised in a recent article published in 2022. Are genes incriminated in the onset of puberty or in the occurrence of precocious puberty? The answer is yes. You can see here a list of genes incriminated. Most important are the kisspeptin, and I think with the advance in genetic testing, there is a lot more to come in the genetics of puberty. What about nutrition? Indeed, there is a nutrition-puberty interaction. In the presence of energy, excess fat cell, and leptin, there is stimulation of KIS1 neurons, leading to stimulation of GnRH, FSH, LH, and this stimulates pubertal development. On the other hand, in case of weight loss or energy deficit, ghrelin takes the upper hand. It suppresses the GnRH, FSH, LH, leading to suppression of puberty. So weight and nutritional status play an important role in the onset of puberty. And this is a happy first period. In the past, parents were so happy when their girl gets her first period or menarche. But to me and to the pediatric endocrinologist, it's not really a very good news because she's not going to gain a lot of height. The average height gain after menarche is 3 to 7 centimeters, which is the problem with precocious puberty. And this brings me to an important question. Does precocious puberty affect the final height? The answer is a very big yes, simply because girls who achieve early puberty are going to have early epiphyseal closure, ending by being short adults. So precocious puberty is the appearance of any secondary sexual characteristic before the age of 8 years in a girl. And as I told you, there are population differences. So the pathogenesis, it's either central when the hypothalamo-pituitary gonadal axis is activated, releasing GnRH pulses, FSH, LH, increasing the sex steroid. Or it could be peripheral precocious puberty when the axis is not activated. And here, the source of stimulation is either the gonads or adrenals, increasing sex steroids, and this negatively suppresses FSH and LH. So simply speaking, if you have high FSH, LH, think of central precocious puberty. If you have low FSH and LH, think of peripheral precocious puberty. And in both ways, you're going to have high estradiol in both types. So the differentiating point here is gonadotropins in order to diagnose the type of precocious puberty. In this busy slide, you can see a list of causes of central and peripheral precocious puberty in girls. The only thing I need to stress about is idiopathic central precocious puberty is the most common cause of precocious puberty in girls, which is the reverse in boys, where tumors are very common in such a case. And sometimes combined precocious puberty when peripheral shifts to central with maturation of the axis. So this was a very short introduction, but my main target is to share with you some of my real life case scenarios and to zoom in with such cases because I believe patients are the best teachers. Now, Mariam is a 3-year-old girl. She came to me because of bilateral breast enlargement since 6 months. There is no history of drug intake. Family history is not significant. Her height is normal at the median. Her body mass index is normal. There is no hyperpigmentation. She is in Tanner stage B3, no pubic hair, no axillary hair, and her external genital appearance was normal. And we love to look at the growth charts in those patients because, as I told you, it affects the height. When we plotted the girl's height on the growth chart, it was completely normal growth. So, thinking of a case with precocious puberty, which investigations to order? Of course, FSH, LH, estradiol. If you are thinking of central or peripheral precocious puberty. If there is pubic hair or adrenarche, DHEAS is the most important. And don't forget to exclude 17-hydroxyprogesterone because it could be congenital adrenal hyperplasia. Remember, if girls have precocious puberty before the age of 6, you have to do MRI brain imaging. It could be a tumor. In boys, we do it all the time, whatever the age. And sometimes we need adrenal and gonadal imaging if needed. Please remember, and this is based on the latest guidelines, that LH is the most valuable biochemical parameter to diagnose central precocious puberty in girls. It's much more important than FSH. Now let's go back to Mariam. We did a GnRH stimulation test. We found FSH high, LH normal, and the serum estradiol was high. We did a bone age, plain X-ray, left hand and wrist, and we found that the bone age is consistent with chronological age of the child. It's not advanced, and the MRI cell tosica is normal. So if I ask you, what is your diagnosis? The answer is premature thelarche, which is very common. And here, which would you treat or wait? Which would you do? The answer here is wait. We do not treat premature thelarche. Please remember, isolated breast development before the age of 8 years in a girl without any other signs of development defines premature thelarche. Such girls will have a normal height, growth velocity, and normal bone age. FSH is high, LH is normal, and estradiol is high. It's usually regressive, but it may progress to central precocious puberty. Therefore, you do not treat, but you have to follow up early. Now, as we know, sometimes when you reassure the parents, they disappear. And this is what happened. When I told them she's fine, come for a follow-up after 3 months, they disappeared for 2 years. And they came to me with accelerated height. As you see, she was normal. Now she's very tall for her age. And the Tanner stage progressed to B4. Pubic hair appeared with no axillary hair. And look how the girl came to me, progress. And when I repeated the GnRH stimulation, I found high FSH, high LH, and the serum estradiol was high. Remember, previously she had a normal LH. Now she has a high LH now. And the bone age is advanced. Her actual age is 5 years and the bone age is 8 years. So this is 3 years advanced. So what's the diagnosis here? The girl progressed to central precocious puberty. And when I asked you treat or wait, of course, here you have to treat with GnRH analog. And this is a quite nice article that summed up the criteria who are likely to have progressive precocious puberty. If you have any of these criteria, you think that this girl is going to progress from peripheral to central precocious puberty. Most important of these is the LH being high and the bone age and the height being advanced. Now, looking at the timeline of the milestones in treating central precocious puberty, it started a long time ago in 1960 with oxyprogesterone and then danazol. And then came the era of the long-acting GnRH analogs. And you can see there is a lot of variety, either monthly, 3 monthly, 6 monthly, and they are working on developing a once yearly GnRH analog. And when the question was raised, which one to choose, actually, we are pressed upon by availability issues. In Egypt, we have the once monthly and the 3 monthly. In other countries, there is the 6 monthly, but we usually use what we have. So conclusions again, some cases of premature thelarche, progressive precocious puberty. In some cases, going to have accelerated height and bone age, high FSH, LH, and estradiol. And remember, the treatment of choice is long-acting GnRH analog. Now, let me take you to another story of my patients. This is Haya. She's a 4.5-year-old girl. She came to me with breast enlargement, no history of drug intake. The mother reported attacks of headache and laughing without a cause. Family history is not significant. The girl is very tall, +2 standard deviation. She's tall for her age. The BMI is normal, no hyperpigmentation. She is in Tanner stage B3, no pubic hair or axillary hair, and the external genital appearance is normal. And when I plotted the growth on the growth chart, the girl was found to be very tall for her age. And when I did the GnRH stimulation test, I found high FSH, high LH, and high estradiol. And as you see, the bone age was advanced. The girl is 4.5 years, but her bone age is 7.5. So the diagnosis here is central precocious puberty from the start because LH and FSH are high. And let me ask you, what is the missing investigation in such a case? First of all, this girl is less than the age of 6 and she has CNS manifestations. So the missing investigation is MRI telangiectasia. So you can see this mass, which was found to be a hypothalamic hamartoma, and the treatment is GnRH analog. Now, the conclusions here, any girl with central precocious puberty and CNS symptoms or atypical pubertal progression must perform MRI brain. Hypothalamic hamartoma is a benign hypothalamic tumor, which is rare, but it's the most common organic brain lesion causing central precocious puberty, so you have to exclude it. Long-acting GnRH analog is the treatment of choice. Surgery is rarely indicated due to sensitive location of the hamartoma and its benign nature. And let me share with you this nice article on gamma knife. And this is a recent modality for treating hypothalamic hamartoma. And this article clearly stated that gamma knife radiosurgery is a safe and effective procedure in treating hypothalamic hamartoma, which preserves endocrine function. Because if you do surgery, we are really worried about the pituitary and hypothalamus endocrine function. And this was supported by another recent article published this year in 2025, clearly stating that gamma knife is a safe and effective modality in seizure control, gelastic seizures, which is the laughing seizures, as I showed you in the case, and it is really useful in patients with small hypothalamic hamartoma, but not the large one. Now, let me move on to another girl. This is Fatma. She's a 5.6-year-old girl who came with breast enlargement in 6 months. and menarche. And menarche is very respectable before the age of 8 years. She also gave history of long bone fractures, no history of drug intake, family history not significant. The girl is very tall for her age, BMI normal. As you see here, she has café au lait patches and breast stage 3 with no pubic or axillary hair. And when I plotted her growth on the chart, she was found to be very tall for her age, plus 2.8. She's very tall. And when I did the GnRH stimulation, this time I found very low FSH with a high estradiol. So this is peripheral precocious puberty, which is totally different than the previous cases I showed you. And the bone age was markedly advanced. The bone age is 9 and the chronological is 5. So this is markedly advanced bone age. So this is a case of peripheral precocious puberty. And we did a pelvic ultrasound because the girl had menarche. We found multiple ovarian cysts. And because of the fractures, we did a bone X-ray. We found multiple cystic dysplasias of the bone, as you see here. So putting these together, precocious puberty, fibrous dysplasia of the bone, and other features, this is Kuhn-Albright syndrome, and it's not uncommon. We have to look for it. So café au lait patches, polyostotic fibrous dysplasia, and precocious puberty, this is Kuhn-Albright. And in cases of peripheral precocious puberty, there is no place for GnRH analog because the axis is intact. In such a case, we treat according to the cause. We give aromatase inhibitors, and these act by converting estrogen or decreasing the estrogen. You can give directly anti-estrogen, sometimes anti-androgens in boys, and sometimes we give combination. So please remember to exclude Kuhn-Albright in any girl with premature menarche. The classic triad here is peripheral precocious puberty, polyostotic fibrous dysplasia, and café au lait patches. The treatment here is anti-estrogen or aromatase inhibitors, plus bisphosphonates for the bones, and we do not give GnRH analog except if she shifts to central precocious puberty. My last case is Jude. And this is a 1.5-year-old girl, Tunisian female girl. She came from Tunis because the girl developed pubic hair since the age of 6 months. And when she consulted the doctors in Tunisia, they told her this is normal. But because the mother is very clever, she felt uncomfortable. And she came to Egypt to have another opinion. There was no history of drug intake. Her height is slightly tall. Her BMI is normal, a little bit of cushingoid features, hirsutism, and no skin hyperpigmentation. And you can see here, there is pubic hair, P3 to 4, with no breast enlargement and no axillary hair. And there was a little bit of clitoromegaly, as you see. When you face a case of precocious puberty, it's very important having pubic hair to ask yourself, is it simple or serious? Because it's totally different. There's something known as premature adrenarche, which is physiological, with mild elevation in Dahlia S and mild growth advancement. We have to exclude congenital adrenal hyperplasia, which is a disease. And in such a case, we're going to have 17-hydroxyprogesterone being high. We also have to exclude adrenal tumors, especially in the first 2 years of life. And in such a case, you're going to have a sky-high Dahlia S. And finally, exclude ovarian tumor, where you're going to have testosterone being very high. So again, having pubic hair could be simple or serious. Now let's go back to Jude. We found low FSH and LH, so it's peripheral precocious puberty. Total and free testosterone were high. The Dahlia S was sky high. This means adrenal source. The cortisol AM and PM was slightly disrupted rhythm, and the ACTH was suppressed, confirming adrenal etiology. And the 17-hydroxyprogesterone was completely normal, so this is not a case of congenital adrenal hyperplasia. And the bone age was not very much advanced. Could be because she's very young and the condition did not occur a long time ago. So let me ask you, what is the urgent investigation in such a case? Of course, abdominal ultrasound and MRI. We found adrenal mass, and we referred the girl to the pediatric surgery As you see here, unfortunately, it was a right adrenocortical carcinoma. Now, look how serious precocious puberty could be. And my take-home message here, with early onset pubic hair, exclude congenital adrenal hyperplasia and adrenal tumors. And don't forget to do 17-hydroxyprogesterone, DHEA-S, and abdominal ultrasound. And so my final conclusions are, we have a very wide spectrum of precocious puberty cases. It could be early, but not precocious. It could be incomplete, like isolated pubarchy or thelarchy. It could be central or peripheral precocious puberty. And the first two are physiological and do not need treatment, and the others require treatment. Incomplete forms could progress to central, peripheral could progress to central, and in such a case, you have to treat. I think you agree with me how complex precocious puberty could be. It's a really, really complex process. I hope I was able to simplify it a little bit. And let me end by telling you, hormones have got a magical effect. And look what puberty does. It does a lot in everything, internally and externally. And since it's really difficult to deal with our healthy teens, and I think every one of you having a teen understands my words very well. It's really challenging to deal with them. So what if there is a medical problem concerning puberty in a child? It's a real challenge. They could drive the doctor, the parents, and the patient crazy. It's really difficult. And so what? Precocious puberty poses a heavy psychological and economic burden, affecting the quality of life of the patient and her family. And this is really important. And even more important, it could be the key to diagnosing a serious medical problem, which is even more serious and important, as I showed you. And finally, I think that the state of the art is to ask ourselves, what lies behind the wall of precocious puberty? Which way shall we go? Is it the pathological type which needs urgent treatment, or is it the simple type which does not need treatment? And sometimes it's a zone or gray zone in between, which is again more challenging. Finally, I think we need to take it step by step to be able to win the challenge of dealing with such interesting and challenging cases. Thank you very much for your attention.
Thank you very much, my dear Professor Rasha, for this very insightful and excellent presentation.
Thank you.
I think you really improved our understanding of precocious puberty, a very important topic. Thank you very much. I think we have lots of questions for you, starting with Professor Yasser.
Okay, so Rasha, it's not a question. It's unbelievable. To be honest, it's more than wonderful.
Thank you very much.
I would like just to attract the attention of the great presentation that we have had, and whoever from you missed this presentation, so I think he missed 50% of his life, actually, to be honest. It's
Thank you, Professor.
unbelievable.
That's a big credit for me. Thank you very much.
It's just simple way in presenting great problem. Thank you very much. To be honest, I am honored to be with us, and thank you very much.
The honor is mine. Thank you, Professor.
I might spend the whole night just to highlight how great you are. Thank you very much. It's wonderful. Great. Thank you. Amr, please start questions. Thank you very much, Amr.
Thank you. Okay, so our first question, who we do GnRH stimulation test, or we can measure directly FSH and LH, I think.
Very good question.
Yeah.
To be honest, the GnRH stimulation test is the gold standard test. It is much more accurate. It is sensitive and specific, especially in girls. In boys, it doesn't differ a lot, but in girls, we prefer to do the GnRH stimulation test. But sometimes the GnRH that we use for the test is not available all the time. In such a case, we can rely on the basal FSH, LH, and estradiol. But if I will choose the GnRH stimulation test.
Thank you. Another question. What's the recommended setup for MDT, and is there a scheme recommended for tackling such case?
Which cases? Sorry.
I think the question is again, what's the recommended setup for MDT? And is there a scheme recommended for tackling such case? I mean, talking about the precocious puberty in general. When to do an MDT and when to just
And
treat.
what does he mean by MDT? Multidisciplinary tackling?
Multidisciplinary team.
Yeah, team?
Multidisciplinary team.
Okay, yes, of course, we need a multidisciplinary team. We need a pediatric endocrinologist. And this is what we have at Ain Shams University. In fact, we have a multidisciplinary team. We have, of course, the pediatric endocrinologist. We have a psychologist or psychiatrist. Sometimes we go for pediatric surgeons if it is a surgical condition. Sometimes we need the neurosurgeon if it is a pituitary tumor, for example, or mass that needs to be excised. And we direct the case according to each case. So it's individual. And sometimes we need a nutritionist, for example, if the problem is nutritional and so on. So it's really variable, but the only fixed person is the pediatric endocrinologist, but we use according. But I think starting from today, we will need the gynecologist probably.
Yes, definitely. Another question, outstanding presentation. What about early menarche and all other parameters of puberty are normal? Just early menarche.
By early menarche, I mean before the age of 10. Premature or precocious menarche, this is before the age of 8. If this happens, you have to exclude McCune-Albright syndrome because most probably it is pathological. You have to do ultrasound, pelvic ultrasound, exclude the presence of cysts. You have to do GnRH stimulation test, bone age, and assess the growth. If everything is normal, just follow up. It could be once in a time, a cyst ruptured or something and will not be repeated. Sometimes it progresses with time and the full-blown picture will appear. But don't take it easy. You have to exclude McCune-Albright.
Yes, definitely. Another question for precocious puberty in general, how often does the diagnosis or condition can be missed by parents since they are the first ones to notice that?
I think it is not missed. Sometimes they are embarrassed to tackle such a condition. This is what I feel because the way they present the case to me, they are a little bit embarrassed. They don't want to have social pressure or things like that, or to put a pressure on the child. But it's not easy to miss a breast in a girl or menses in a girl. I don't think they will just say this is normal. And this reflects the need for awareness to make people have the courage to go to the doctor, to the specialist and say, yes, my child has got precocious puberty, or I'm not sure whether this is a problem or not. And the doctor will decide. So I think it's a matter of awareness. But of course, they can find changes in such girls because it's not easy to miss. Maybe in boys, it's not very clear. In girls, it's very clear to find.
Okay. Another question, when we need to give growth hormone and in which case?
Oh, expert people. These are not gynecologists. These are endocrinologists. Very deep question. Okay. Let me tell you that the first line of treatment is the GnRH analog. Sometimes when we do a bone age plain X-ray left hand and we find that the height potential is going to be bad and the child is going to be short, we add growth hormone to the GnRH analog to improve the final height. But this is not FDA approved. It's a good option, but yet it's not FDA approved. My experience, I do it and the results are very good. It improves the final height because sometimes the time is very tight.
Thank you. One last question. In McCune-Albright syndrome, there is an autonomous estrogen production by the ovary not controlled by FSH. Yeah. So it can consider as ovarian tumor?
It's not a tumor, it's a cyst. It's not a tumor. McCune-Albright occurs due to defect in the G protein signaling called GNAS protein. And this causes autonomous secretion of different hormones. For example, ovarian cyst secreting estrogen, the thyroid secrete excess T3 and T4, the pituitary secretes excess growth hormone, and so on. So it's an autonomous hypersecretion in different organs. One of them is the ovary. It's not a tumor, it's just autonomous hyperactivity. This is the accurate description.
Thank you very much. We have like 40 comments. Most of them just thank you for the presentation.
Thank you very much. My pleasure.
Really, it was really an honor to have you with us today. Thank you very much for sharing
My
your
great pleasure.
expertise and your knowledge with us. Thank you,
Thank you
Professor
very
Ashraf.
much. My great pleasure.
Okay, now moving to our next speaker, it gives me a great pleasure to introduce Dr. Muhammad Hassan. He is a consultant in obstetrics and gynecology. He is the treasurer of the Egyptian Representative Committee of the RCOG. He is also a treasurer of the Egyptian Society for Colposcopy and Cervical Pathology and scientific board member in many societies. Dr. Muhammad will be presenting a very interesting topic, intersex. So please, Dr. Muhammad, start your presentation.
Good evening, Amra, and good evening, everyone in this respected room. I'm very happy and proud to be a speaker today in this webinar conducted by the ERC-RCOG Egypt. And actually, I choose this topic, which is not an easy one, because we have a limited information in our studying during the basic science and the early years of training regarding such problems, because these problems are complicated and many people should be involved in the management of such cases. So I will try to simplify every single scenario that we will going to explain today. To start with a very simple introduction, that we need to redefine the terms one more time, because the intersex is not the ideal terminology to describe a group of diseases that affect either men or women in very early age. It's now known as DSD, which is the disorders of sex development. And these problems are related mainly to the sex assignment at birth, and sometimes in rare conditions, the situation may extend to the late onset appearance of the problem, or when even the woman started her sexual life or start to think about pregnancy and being a mother. So the symptoms may represent very late, and it will not be ever a happy surprise to discover the problem. And the purpose of this presentation is to understand more how can we identify the common intersex disorders or DSD disorders, and how can we manage them. So simply, if we are trying to understand the causes of intersex problems, we can summarize them into genetic mutations, when sometimes the genes responsible for sex development are defected, or hormonal imbalances, when there is abnormal levels of sex hormones during the development. And finally, which is very rare, exposure to certain materials like chemicals, like drugs during pregnancy. But this is definitely a sporadic finding that is not running in the families. So again, the types of intersex, including a patient, 46 chromosomes, XX, they are genotype female, but they may express as male, either by featured secondary sexual characters or the genitalia. On the other hand, a male, a pure genotype male, 46XY, may represent with external female genitalia and or the secondary sex characters of a woman. And sometimes there is a true gonadal problems, which means individuals have both gonads inside his body or her body. So the patient has both ovaries and testicles within her formation. So these are the most common types. And if we are thinking about the diagnosis, we can go through the prenatal testing when there is any suspicion regarding the ultrasound scan or a positive family history of gonadal problems, DSD problems in the family. So the fetal medicine consultant can decide, according to the ultrasound findings, to go for deeper investigation, like amniocentesis for karyotyping. And this is a definite diagnosis of the problem. And fatal by physical examination, requesting karyotyping and hormonal and imaging studies, like what we are going to discuss. But we will just put a broad lines for the plan of management because the problem is complicated, as I said. So if we trying to put a plan of care for such patient, many people should be involved in the management and in decision making. Number one is the patient herself. If she is, a major patient, I mean above 18 years old, and her mental capacity is full, she is the most important one in taking a decision regarding the plan of care. But additionally, of course, we have a very important personnel by the team, endocrinologists, genetic counselors, and psychological counselors as well, playing a fundamental role in managing the case. And finally, the surgeons who may play a role in reconstruction of external genitalia, or sometimes they are maybe going to remove the unnecessary organs, gonadectomy. The hormonal therapy is critical sometimes to induce puberty in those patients, and the surgical interventions, the reconstructive surgery, if necessary, sometimes playing a very important role to restore the regular possible life for those patients. Sometimes the Mullerian duct will not develop well, so the patient may have, for example, a short blind end vagina. So what we can do is to do a vaginoplasty, so helping the patient, for example, to restore her sexual life. This is the least thing she can restore. And of course, the psychological rule. So we are trapped in managing those cases in ethical important considerations, okay? Because the problem is, like it's a diverted problem. So we have many backgrounds to be discussed while you are dealing with such away from the medical and scientific point. We have a traditional point. We have a religion and religious points. So we need to ensure that the consent is obtained from the patient prior to start doing any manipulations, as well as the confidentiality of those patients are critical. Now, additionally, the human rights and cultural sensitivity should be respected, and those patients should definitely be managed in, multiple levels. Now, let's start like going in depth a little bit, just to save the time. Yes, let's discuss the most common scenarios that may be found in practice. Now, it's very easy to say a boy looks like a girl. What does that mean? It means a boy that the genotype is XY, okay? This is by karyotyping. But the boy looks like a girl as a secondary sex characters maybe, and the external features. We called it like phenotype. So the phenotype is a girl, the genotype is a boy. And we have a very famous two conditions related to this scenario: the androgen insensitivity syndrome and the Swyer syndrome. Now, the differences are very limited between both of us. Both are due to some problems in the androgen effect, the sensitivity to receptors in androgen insensitivity, there is a good amount of androgens, but receptors are not responding well. This problem is starting very early in utero life. That the patient has no ovaries, no uterus, and there will be definitely atrophied testicles intra-abdominal, wherever. It could be in the anterior abdominal wall, it could be in inguinal ligament, wherever, it doesn't matter, but the testicles will be there. Due to the preferential conversion of the androgens to estrogens, so atypical secondary sex characters will be found in those patients, and the external feature will be like under degree feminine appearance. So it will never be a full woman like in phenotype. So for example, the breasts will be underdeveloped and there will be a sparse hair distribution. Okay. In Swyer syndrome, the problem is different a little bit. There is a very important gene called SRY gene, SRY gene, on the Y chromosome, which is releasing in utero around 4 weeks a critical material called MIF. MIF, the Mullerian inhibitory factor. All of you knows the fact that the precursor of all babies is female. Okay. And then if the genotype of the baby is XY, the Y chromosome through the SRY gene starting to release MIF, the Mullerian inhibitory factor. So the Mullerian duct start to vanish and the Wolffian duct start to raise, to develop later on the male genitalia. What happened here in Swyer syndrome, that the release of MIF is delayed a little bit. So the Mullerian duct started to be developed. So in this patient, you will find the uterus, but it's hypoplastic uterus. It's atrophied uterus. It's infantile uterus. Okay. And again, because of the development of Wolffian duct later a little bit, the testicles will be intra-abdominal and there is no ovary. Now, simply, these are the problems in both scenarios. So, how can we manage? Simply, testicles should be removed. So gonadectomy should be done, and preferably it should be done as soon as possible in Swyer syndrome, while we can wait a little bit until the age of natural puberty, around the age of 18 years, in androgen insensitivity syndrome. This is maybe because the risk of cancer transformation. In Swyer syndrome, the undescended testicles are turning into malignancy in about 20% of the cases, while in androgen insensitivity syndrome, the risk is only 2%. The hormone replacement therapy is very important because this patient is apparently female. Okay, so the decision will be simply that she should continue her life as a woman. This is very critical, and let me rapidly explain this. The sexual identity is not only related to the external genitalia or internal genitalia. The sexual identity is a behavior as well. So if a patient spent 18 years of her life dealing with people and people dealing with her like a woman, so she is a woman, regardless the genotype. So we need to support this XY patient to be apparently XX woman. Okay? So the behavior is very respected issue in determining the sex orientation. Hormone replacement therapy here is critical. Let me give you a very simple trick, okay? Now, it's critical that if the patient had a uterus, so I need to give her combined estrogen progesterone HRT treatment. This is in Swyer syndrome because the patient had still infantile uterus. So if you give her estrogen replacement therapy alone, you are putting her in a potential risk of endometrial cancer. So please notice that in androgen insensitivity syndrome, we are just giving estrogen replacement therapy. But if we are dealing with Swyer syndrome, we have to give combined estrogen progesterone therapy. Okay? Now, the vaginal dilatation or dilators or trainers are very important if there is an associated vaginal hypoplasia with the patient. Okay? It's very critical. And we either the trainers or the dilatation with dilators or going for a vaginoplasty procedure. Psychological support is critical. Gender identity is typical female. This is what I said, the gender identity, but this is our rule to support her and keep her in that way. Okay. Now, let's move to another situation. We will play the game from the other side. Like a girl who looks like a boy. Okay. Now she's a genotype girl, a woman with XX, but unfortunately, she looks like a boy. She has the criteria, the hair distribution, the deepening of voice of a boy. So there is a very famous autosomal recessive disorder with very wide internationally called congenital adrenal hyperplasia. Now, the congenital adrenal hyperplasia is a problem with the adrenal glands that we have a deficient hydroxylase 21 enzyme. In this enzyme deficiency, the patient have a serious problem with mineralocorticoids secretion. I mean, the aldosterone and corticosteroids. This is, by the way, also the most common cause of ambiguous genitalia. When you deliver a baby and you and the team in theater cannot determine is it a boy or a girl. So this is very critical. We have two types of congenital adrenal hyperplasia. The classic one, which is presented early at birth with severe cortisol and aldosterone deficiency, leads to a life-threatening salt loss, dehydration, failure to thrive. But this is not important because we are not pediatricians or neonatologists. Actually, we are concerned about the second one, the non-classic, or what we all know like a late onset congenital adrenal hyperplasia. In congenital adrenal hyperplasia, it's a mild form of the problem of cortisol and aldosterone loss or deficiency. And that's why the symptoms appears later in adulthood, and it's maybe associated with amenorrhea or oligomenorrhea with apparent virilizing symptoms, virilizing masculine symptoms, and of course, hirsutism with acne, a picture of high androgen levels. Now, the diagnosis, she showed us a very beautiful slide in her respectable presentation. regarding the differentiation between the premature puberty and the adrenal tumors and congenital adrenal hyperplasia. So significantly and pathogenomically, the presence of 17th hydroxyprogesterone in urine is a landmark for congenital adrenal hyperplasia. So the diagnosis is easy. Once you have any suspicion with the patient, the diagnosis is easy. If you offer the patient karyotyping, the patient will be definitely XX with excess androgen production. So the treatment is easy as well. We are just dealing with the hyperandrogenemia. So we can use the combined pills to control the hirsutism, acne, and the hyperandrogenism, preferably to use the Diane with a very famous specific progesterone compartment called cyproterone acetate. And if it's unavailable, we can go for adrosprenone components in combined oral pills. In some resistant cases, we can choose the anti-androgenic medications like flutamide or finasteride. And of course, the patient will keep on her life with the steroids, either prednisolone or hydrocortisone. Please notice here that because of the patient is XX and there is no problems with ovarian development, so no need to give the patient HRT treatment, okay? Once you try to control the androgen excess production, relatively, the estrogen production from ovaries will increase. So the patient will be in a suitable hormonal balance. Okay, the third group of DSDs, now we talked about a boy looks like a girl and a girl looks like a boy. Now the third group is a patient with abnormal karyotyping, but it has a very critical and very famous criteria. The Klinefelter syndrome is a very good example for XY, and Turner syndrome is a very important example for XX. Okay. Ordinary looking genitals, but different sex development. Some people have a different chromosomal pattern. If I have a patient with XY, he's a male. But sometimes we have a problem with XXY, the extra X chromosome. Okay, this is equal simply a Klinefelter syndrome. I think from the picture, we can notice the clinical findings and clinical features, the tall stature, the gynecomastia, the feminine fat distribution of the body, as well as the feminine hair distribution later on with, of course, azoospermia or fertility problems. The treatment in such cases is a symptomatic treatment and solving the problem of the situation. If the Klinefelter is looking for fertility, so we can go for a TASA, looking for any spermatogonia. If it's found, we can go for XC. If not, so we can go simply for sperm donation or adoption. On the other hand, if we have a woman with XX genotype, but we lost one of them, now she is XO, this is a very good example for a Turner syndrome. When the woman external genitalia is matching with genotype, but we have some different findings in clinical features. A short stature woman with webbed neck, wide spaced nipples, and some intellectual dysfunction, maybe in some cases, with higher risk of coarctation of the aorta, leads to hypertension, chronic hypertension. This group of DSDs is very famous with mosaicism. Sometimes the findings there is a huge variation in clinical presentation in the same problem group. For example, the Turner syndrome is very well known in women with amenorrhea, galactorrhea, and infertility. 15% of Turner syndrome are mosaic Turner. So they are prescribed like 45XO, 46XX combined. Simply, this woman, the mosaic Turner, will present with periods. She can get pregnant spontaneously, but definitely she will be represented with premature ovarian insufficiency very early. And this is the core problem of XO women with straight gonads. So what I would like to say finally, in such group of patients, please, not all tall women are Klinefelter, and not all short stature women are Turner syndrome, because the variations are too much, and you should follow the rules of diagnosis precisely to identify the problem. And once you have any suspicion towards a diagnosis of a patient, don't hesitate to request karyotyping, because surprises are always there. I think we got the point of the intersex. I don't know if I spend a lot of time, I apologize, but I wish that hello, Professor Yasser? Hello?
Yes, I'm here.
Yes, I think we got it, and we classified the groups of intersex into major three groups. And the final message I would like to say is deal with these problems very sensitively, because the aspects of the problem are very wide and abundant, and you need the multidisciplinary team with you to cover all these aspects. And if you have any problems in the diagnosis, don't hesitate. Go so much, and I'm ready for questions if any are available.
Thank you very much, dear Dr. Muhammad, for this, firstly, choosing this very challenging and sensitive topic, and for delivering this presentation in such an amazing way. I think you covered the whole medical, cultural, ethical, and humanistic points of view. Because we're running out of time, we'll take just a couple of questions. So the first question will be from me. When gonadectomy is indicated, do you think it's better to do it laparoscopy or laparotomy?
When it is indicated, once the patient is confirmed with XY genotype, so the testicles should be removed. So how can this is a very important question, Dr. Amr. How can I remove the gonads? Now, if the gonads are palpable clinically through the groin area and the abdominal wall, if they are palpable, I can go directly by a surgical removal. Now, if they are more deep towards the intraperitoneal cavity, so I can try the laparoscopic approach. Now, if it's more and more and I can't feel it, I can't find it intra-abdominally as well, I can go for ultrasound guided wire. Okay, a guided wire ultrasound, just to identify the exact location of the gonads, and then I can go for surgical removal. This is a very important step done with collaboration with interventional radiologists.
Thank you very much. Thank you.
Thank you. Because in many of cases, the gonads after many years, if the diagnosis of the condition is late. So the gonads themselves are so much atrophied and embedded in the tissues. So sometimes it's really challenging to exactly locate the gonads and remove them.
Yes, thank you. One last question, because we're running out of time. Now, new area of uterine transplantation for androgen insensitivity syndrome is valid option in such cases, do you think?
Now you will take me in a very debatable and challenging topic, because the uterine transplantation worldwide is accepted practice, and the first time it was done successfully 10 years ago in Sweden, and then in UK recently in the last 6 months it had been done as well by robotic surgery and microvascular interventions. But because of some religious backgrounds which should be respected in our area in the MENA region, so this practice, I think we are far away from the uterine transplantation ideas. However, in patient needs a uterine cavity, or instead of uterine transplantation, we have still some religious acceptance towards the surrogacy, which can play the same role with those patients.
Again, thank you very much for your wonderful presentation and choosing this topic. Thank you very much.
Thank you so much.
Now
thanks everyone, and thanks Professor Yasser to give me the chance.
Thank you very much. It's wonderful, to be honest, and I think it's a very difficult topic. So you did well. It's great. Thank you very much. It seems that today is a celebration for achievement, and get lots of new information regarding to adolescent gynecology. Thank you very much.
Thank you. Now it's time to welcome back Professor Yasser Abu Talib, but this time as a distinguished speaker. Professor Yasser will be shedding the light on female genital mutilation and how healthcare professionals can provide effective care and support. So please, Dr. Yasser.
Okay. So okay, so hi all again. I know that we spent a long time just discussing the intersex and precocious puberty. So what's about shifting to another historical problem or mutilation, which we used to face all over all over Egypt, Africa, Arab countries, and many countries as well. Let's go and promise that we're not going to spend a long time, and I hope to enjoy, because there is an operative intervention that I will show to you how can we manage in a very simple way. So let's have an agreement that female genital cutting, despite the fact that it carries great risk, but still not in Egypt. This is a surprise. Not in Africa, not in Sudan only, but it's worldwide practice. Why? And the answer comes straight away. It's nothing except tradition, and that's it. Going through the history of this practice, how it was born, it's certainly, we don't know when was the first time to be done, but some said that it's 5th century BC with the first people who did it in Egypt, and at that time, at ancient time, Egypt and Sudan was both of them are the same. However, what settled down that in the 3rd century, Philomenus of Alexandria in Alexandria described this practice as a way of improving the life of his friends, because he was sitting with his friends and everyone started to complain that his wife got problem with the genitalia, which is disfigured, and he cannot have proper sex and enjoyment. So he asked them to just send them to him, and he managed actually to reshape, which is plastic surgery, the external genitalia to be in normal anatomy, serving normal physiology. However, Egyptian people take this practice and start to modify it as usual. You know, Egyptian people like very much to create something new, and they have this practice, and instead of just to improve the shape and help people to enjoy sex, they take it as a way of prevention of extramarital sex, which is sound very strange for married and unmarried people as well. This is a problem. 3 centuries afterwards, because of the French people, the British people used to come to Egypt and start to keep everything in place. They start to transfer this practice to Europe. That's why Monsieur in the 6th century in Europe described in the first book, gynecological book, all over the world, which was raised this problem, and he described excision of the hypertrophic clitoris as a cosmetic reason and diminished excessive sexual stimulation. 14th century afterwards, and in the 20th century, the UNICEF and WHO raised a very strong announcement, and they raised a red flag. People all over the world, we are warning you that female genital cutting is a very big problem. Why? It carries 2 things. It's worldwide, so it's not in Egypt alone or Sudan alone, but it's all over the country, all over the countries, all over the world, and carries great risk. In the year 2016, the UNICEF mentioned that the total number in 30 countries, not in Egypt and Sudan alone, in 30 countries, including European countries, about 200 million girls had circumcision. The point is 54 millions were under the age of 14. Do you know what this means? It means that this genitalia that was excised and these girls escaped with their life and were lucky not to have strong bleeding, regrowth of the external genitalia, and they will exposed again to circumcision again, which is a horrible thing. Let's have a look at this map, which was presented by the UNICEF in the year 2020. I discovered something very, very strange. Do you know why? Do you know what that? The number of countries where female genital cutting is practiced all over the world, it's nearly 100 countries. 51 of them only prohibited doing that practice. And as we see here, it's in Africa, in Mexico, and Australia, and in Far East as well. But it's a huge number of people used to have this practice. And what's about the situation here in Africa and Arab countries? In Yemen, 19%. This might be acceptable. In Egypt and Sudan, it's 87% of girls might be exposed to female genital cutting. And again, if we said that acceptable, but Djibouti and Somalia, it's a horrible thing. Nearly 100% of women in Somalia used to have this female genital cutting. What's surprising as well, and it's very dangerous, that nearly in Egypt, and according to the FGM, according to the UNICEF and the WHO, that medicalization of the female genital cutting is there. Nearly 65% of girls has female genital cutting came this practice from medical people, from doctors, which is very dangerous. So what's female genital cutting? As you see here, it's coming from this reference actually, and let's have a look to this picture, because people who used to do it non-medical people used to use that picture. They used to put sand in a pan and put charcoal and make a fire. Then they used to use this machine or this mousse just to heat it and to become very hot as a way of sterilization. And they used to use it to cut the external part of the external genitalia. Why? Because it will be heated, so high temperature, so it will cauterize, cut and cauterize at the same time. So sound very strange and very silly. According to the international programs all over the world, female genital cutting might be type 1, type 2, type 3, and type 4. What's type 1? Type 1 is cutting the clitoris, because people actually thought to some extent that clitoris is the source of sexual excitability, so they cut it. So this type 1. However, they discovered that the lady is still in active sexuality, so they invent type 2 by cutting the clitoris and the labia minora. Why? Because both of them become erectile and increase in size because of blood flow during sexual excitement. So they thought that labia minora might be the source of sexual excitement, so they cut it. Both of them, type 1 and type 2, are the most common one. However, the most dangerous one, which is used to be done in South Sudan and in Somalia, it's type 3. What they do in type 3? So they discover that the sensitive area as well, which make the one excitable, the clitoris, the labia minora, and not only that, after they cut both of them, they discovered that the lady still in active sexually and she might have a sexual excitement, and they discovered that the area of excitement is the vestibule, so they cannot remove the vestibule. That's why they discover as something very strange. They used to cut the strips of skin from the labia majora right and left, then suture the inner layer, the inner flap of the skin right and left, and as well covered this layer with the external layer from both sides. So at the end of the day, they will cut labia minora, clitoris, and cover the vestibule in this way. And this situation will end up by just opening, through which menstruation, urination, intercourse, and baby delivering will come through this opening. This is called infabulation. Let's have a look to the picture after infabulation, and you will see this. It's completely obstructed, and this is the site of clitoris with a small opening. The second one, they might be generous enough to leave bigger opening to have intercourse or to have menstruation. However, something might occur, which is clitoromegaly and retention cyst in the clitoris. So it will end by this picture, which is very big cystic changes in the clitoris and very small, minute opening downward. What's about type 4? Type 4, it's any other thing, which some plastic surgeon and the cosmetic surgeon used to put rings or something like that, which is not natural, but they start to put tattoo, do burning, do cutting, to bring something like that. Is type 4. And type 4 is the mildest form. So the most common is type 1 and 2. Type 4 is the mildest form, but this one is the most dangerous and the most difficult one to be managed. What about the complication? Just close your eyes and start to imagine any complication in the world, and this will occur. And we can summarize the complication in 2 forms. It's either mortality, death of the baby. Why? Because the clitoral artery will cut and difficult to be controlled. It's an artery. So it might end up by bleeding, death, or death from severe pain because they don't use any type of anesthesia. So pain might be occur from hemorrhagic shock or neurogenic shock. But if this girl was lucky enough to resume her life, let's have a look to this complication: incision site, urinary tract infection, retention, dysuria, infertility, scarring, and obstructed labor. It's not only that, but in some areas where this poor practice done, they used to use the same instrument with everyone and use it in another things with the patient who are addict or cut some things in the scan, so they might transfer other diseases like hepatitis and HIV as well. So I cannot tell you how much it's dangerous and awful. If everything went right, definitely this girl will develop what's called psychological shock. And the point is, she will hate her father and mother because they push her towards that. So she will antagonize and try to avoid her family because they did to her this against her will. And as well, she will have a very difficult intercourse, difficult relation, no sexual relation. So it means that this practice damaged her life. What's about the management of this case? Type 1 and type 2, no treatment at all. But what we do, because we cannot reconstruct what they removed, we cannot put or create another clitoris or another labia minora. But the aim of the treatment is to refer her to psychological and psychiatry doctor, just to support her and try by all means to relieve her worried about sexual intercourse and let her to live her life. And it's very difficult, by the way. It's not that easy. What we can do and interfere or to correct to some extent, it's the third type of FGM. And let's have a study which was published in on the PubMed and in reproductive endocrinology in the year 2017 by Ryger and his colleague, that include, it's a meta-analysis, includes 71 studies and huge number of patients included in this study. They collect the data and start to analyze it. They found that the common reason for seeking surgical intervention by these people with the third degree, where we cut the labia minora, cut the clitoris, and cut the labia majora and start suture it and close this area completely, it's four things: sexual problems, cyst formation, clitoral cyst, very poor shape of the external genitalia, and identity recovery. So three types of intervention would evaluate it. What's called de-infabulation, cyst excision, and reconstruction. Let's go one by one. What's de-infabulation? Despite the fact it's just nothing except cutting and opening this labia majora, so it has the advantage of easier birth and improvement in sexual life. However, it has a low social acceptance. Why? We shall see in the next slide, because what we do actually, as we see here, this is the small opening. So we catch it by Alice on the right and Alice on the left, and do infiltration anesthesia from up down by xylocaine 10%. Okay, so we dilute it to become 0.5% dilution, and we start to inject it in the middle of this skin, and after that we start to cut it by scissor upward. So we open the labia majora, which will be retracted on the right and the left side. And what will happen afterwards? We will discover that we have an inner flap of mucosa and an outer flap of skin. So there is separation between the mucosa here and the skin here. Are we going to leave it? Never ever to leave it, because it will be a very poor shape. So what they used to do is just to close this space between the mucosa and the skin by suture it in interrupted manner. Is it good? Let's have a look. It's a surprise. Have a look and try to appreciate what the girl will feel. Me, myself, when I see this case, I start to cry. Do you know, you cannot imagine how much it's ugly. So this is after the infabulation. We cut it vertically, and this is the mucosa, and this is the skin. And after that, we used to suture this mucosa to the skin, just to coapt it, as you see here. This mucosa everted on the skin. We suture this mucosa to the skin by interrupted suture. So this is the end and the shape of the vagina and the vulva after infabulation, as you see here. Post-operative appearance. It's ugly. That's why they would prefer to avoid infabulation and keep the shape like that. So the problem here is disfigurement. There is no labia majora, and the introitus markedly fibrosed and as well markedly narrow. So we have some sort of modification. We ourselves in Ain Shams University and me. So the problem is, number one, there is no labia majora. So we start to adopt another policy, despite the fact they are very few numbers. We start to collect fats, okay? To have fat harvesting fats from special area, especially this area, and from the side, and prepare it and inject it upward to create artificial labia majora. So instead of having this picture, we injected the fat here, here and there, so it will bulge outside, covering this ugly picture. That's number one. So two things are there. Marked narrowing as well. Marked narrowing of the vagina, and this fibrosis between the mucosa and the vagina. What we have done to the narrow vagina, vaginal introitus was managed by what's called Fenton operation. What's Fenton operation? Vertical incision at the middle part of the posterior vaginal wall. It's vertical incision, then put two Alice's here. This is vertical incision. Put Alice here and Alice there, and pull it to the sides and start to have stitches. So cut vertically and suture it transversely. So in this way, we widen the space, and the vagina become more rounded and more wide instead, instead of being very narrow. And what's about that? What's about that? The third one is the area of fibrosis between the skin and the mucosa. And we have invented something new. If you know Mackendorf's operation, which is artificial vagina, in which we used the amnion. This is the placenta, and we used it to deliver the placenta immediately during this operative intervention from a lady delivered now, and have the membrane. As you know, the membrane, it's amnion and the chorion. The chorion is facing the placenta and the amnion facing the baby. So what we used to have this membrane separated to amnion and the chorion, and have the amnion. This is the chorion and this is the amnion. We separate them, clean them, and have the amnion. What we are going to do with the amnion is just to put it here in this fibrosed area and fix it. Fix it by what? Fix it by multiple stitches and support as well, and leave it for 2 to 3 weeks. at the end of the day, this is a surprise. Why? Because this fibrosed area will change it completely, and that this amnion which we put will change, and metaplasia will occur to become the same like vaginal mucosa. So disfigurement by infabulation was what we have done. Disfigurement, we have a sort of adhesolysis, fat injection to create labia majora. That's number one. Number two, for introital fibrosis, amnion grafts, and using monocreel sutures and the injection of BRB, which will help to clean the fibrosis and healing process. And for narrowing, we used to have Fenton operation. This is for de-infabulation, okay, to improve the shape, and it's going well. However, we wanted to do more cases to prove that it's working well. Another complication which used to come, as we see here, this is one of my patient. This is a clitoral cyst which occurred due to obstruction after cutting the genitalia from outside, obstruction of the glands around the clitoris, and obstruction results in what's called clitoral cyst. As we see here, this is the clitoris, this is the clitoris, and this is the cyst, this is the urethra, and this is the tiny opening of the vagina. So what you are going to do, don't be afraid, it's very easy. What you are going to do is just to cut this cyst or remove this cyst, but don't open it from the middle side, but you have to have an incision between the labia minora or between the cyst and this side of labia majora, so as when you stitch it afterwards, it will be hidden between the labia majora that you create and between the skin on the clitoral cyst. So it's elliptical incision, and start to dissect the skin right and left and remove the cyst. Here is the cyst, we removed it, okay? And there will be a very big space, as you see here, between the labia majora and the labia minora here, okay? After removing all of that, we have to stitch that. To stitch what? To stitch the labia minora here, not here to there, but the labia minora to the skin. So what we have done, this is the stitches where we stitched the labia minora to the labia minora, approximating it, then close the subdermal part, then close the dermal part. So it will be hidden completely between the labia majora and the labia minora. And this is the final shape of the lady afterwards. Ladies and gentlemen, thank you very much to listen to me to this social problem, and the recommendation and the conclusion from the International Journal of Obstetrics and Gynecology long time ago, and still was renewed in 26th of December in the year 2022, that de-infabulation service must be there. And guideline would benefit from being updated to reflect the needs for survivals and ensure consistency in provision. So please, the most important thing, try to counsel and to counsel and to counsel against medicalization of this process, because it has nothing to do with sex. Sex is here. Whatever you are doing, don't harm girls and cause them to destroy their life. This is one of the most important things. And regarding to the doctor practice, this awful thing, try to avoid them and try to consult them or to speak with them to avoid this, because of the lots of complication. And lastly, thank you very much to listen to me. If you wanted to ask about anything, I'm ready to answer. Thank you very much, it's to you.
Thank you very much, my dear Professor Yasser, for this very excellent presentation as usual. Although it was very clear in the presentation that this is a very harmful practice, you showed us many management approaches to such challenging cases. That was very nice and impressive. Because we're running out of time, may I ask you if we keep the questions after the next session?
Yes, please. Yes, please. Carry on, Amr. Yes. Thank you very much.
Thank you. So let's turn now to our final speaker of this evening. May I introduce Dr. Hala Eddamanhouri. She's a consultant obstetrics and gynecology. She's consultant quality of healthcare. She's a sexual and reproductive health expert, editor of the Arabic version of SRHM Journal, and a global board member and country representative of Faculty of Sexual and Reproductive Health. In her talk tonight, she will focus on FGM from multiple aspects, including statistics, common misconception, efforts to end medicalization, and deeper analysis of root causes. So would you please start your presentation, Dr. Hala?
Professor Amr, can you see my presentation?
Yes, we can see it, Dr. Hala. Thank you.
Can see it now?
No, now it's not there. Yes.
Now it's there.
Just 1 second. Yes.
Good evening, everyone. I know last presentation is not is not the best, but I promise I'm not going to take a lot of time. I express my deep appreciation for the Egyptian Royal College Committee and for Professor Yasser Abu Talib. Thank you for the kind invitation. He already presented a very good wrap-up for the female genital mutilation. My presentation will focus on the medicalization, and my title is When Tradition Meets Medicine. I will address 5 points in my presentation. My presentation actually is not a medical one. It's taking... First of all, I want to express my deep appreciation for the ERC and Professor Yasser Abu Talib for inviting me to talk in this valuable webinar. I will start my presentation today about when tradition meets medicine, and with concentration in medicalization of female genital mutilation in Egypt. My presentation will address 5 points, starting from statistics globally and with focus in Egypt, of course. First, I will start with the definition of medicalization. What's medicalization? We know the shift from historically from the herbal healers and the traditional healers to the doctors. But female genital cutting is not considered as a medical procedure or medical intervention, and it was widely performed in Egypt by dayas and barbers and etc. Now is adopted by medical staff, healthcare providers, and is defined as practicing non-medical intervention by healthcare providers inside the healthcare facilities or elsewhere, doesn't matter. It is worldwide present, ranging from 1 to 74, average 18% everywhere, but in Egypt we are exceeding this average. Our percentage is 74%, as calculated by CAPMAS Family Surveillance in 2021. Before heading to the medicalization issue, I will wrap up quickly the recent updates about the female genital mutilation generally all over the world. And I start with the UNICEF report in 2024. This map represents the countries that have nationally representative surveillance periodically and accounting the female genital mutilation. Of course, the code colors represent the prevalence or the load of the procedure in different countries. Here, Egypt, we are with the highest countries, with Sudan and etc. What is surprising in this report actually that the number of circumcised female worldwide is 230 million women, with increase 15%, which is equivalent to 30 million women compared to the data released 8 years back. When we come to other reports released from leading organizations in the world like Equality Now organization and other USA and European organizations, we will have this map. This map actually added to those countries with nationally representative surveys, other countries, and collected data from different sources, like indirect estimates, small-scale studies, media reports, and anecdotal evidence, and etc. And they found the load of female genital mutilation all over the world is found in 94 countries. And taking those color indicators according to the load of female genital mutilation, the highest one is the blue, and Egypt, of course, between the highest countries. And they as well did color indicator for those countries which have criminalization law for the female genital cuttings, and those countries that have legal prohibition are 59 countries from the 90 in between the 94 countries. Actually, a lot of details in this map. This is another map, but without the prevalence load, just counting the countries that have FGM. And from this map, we focus on the Middle East and some political classification. We have many political classifications for the Middle East. This with focus on the Gulf countries and other countries of the Middle East. We will find that other countries are added to the map that we previously historically considered that they don't have female genital mutilation, like Saudi Arabia, like Emirates, like Kuwait and Qatar, Iran, and etc. Those in blue, which is Iraq and Yemen, they have a nationally representative surveillance. The number of female genital mutilation in these countries are 6 million. I will come back to Egypt. Actually, we are progressing in decreasing the numbers of female genital mutilation, especially with the young generations. We have this projection 18% from 0 to 17, but we know actually that the main age of performing the procedure is from 8 to 9 age of the girls. So from 0 to 17, it's an optimistic measure. It will definitely increase. In the light of Sustainable Development Goals, goal number 5.3, which aims to reach zero tolerance by 2013, how can we measure our progress? How can we benchmark the progress of Egypt? Yes, it is good, but it's not good enough. I will come to this important figure actually, and this is Egypt. This important figure is counting the achievements of different countries towards the 2030 goals and making projection of the curve depending on the current efforts done in each country. We will find 8 categories, Egypt in the 5th category. When I will come to the first one, there is progress, and they will touch the zero line before 2013. This group of countries, they will touch the zero line exactly by 2030. When I come to the group, including Egypt, when I'll make projection to this line and extend directly, so I will touch the 0 point. To touch the 0 point, I need more 50 to 60 more years maybe. So the calculation here said at least 10 times efforts faster than what we are doing is needed to reach zero tolerance by 2013 and achieve the Sustainable Development Goals 5.3. Coming back to medicalization, it is growing worldwide. From the previous statistics, approximately 1 in 4 survivals of female genital mutilation is done by healthcare providers. And of course, the percentage is much higher with the younger generations, as in Egypt, as everywhere in the world. When I come to Egypt, medicalization in Egypt, this is the orange is the percentage of female genital cutting comparing 2014 to 2021. We find the decrease in the prevalence, but when we measure the medicalization, it was 31 in 2014 and now it is 74, with increase more than double. This is the trend in Egypt as well. We have decreasing female genital mutilation while the medicalization is increasing across 1995 to 2014. And this is another calculation by the SAIPE report, which was done in 2014. In green is the FGM performed by the medical personnel, and we can find the increase in female in medicalization with the younger age group. Here is an exciting, interesting slide showing how Egypt and Sudan have the highest load of medicalization, but still Egypt is unique. Egypt is unique in that doctors most commonly undertake female genital mutilation and cutting. So this curve, actually, this drawing explain that the medical doctors in orange, doctors, are performing 67% of female genital cutting in Egypt, while medicalization percentage is nearly equal between Egypt and Sudan, but Sudan has no doctors indulged in performing this ugly procedure. They have only nurses, midwives, and other health workers than doctors. And we can find the percentage of share of medical doctors in female genital cuttings in other countries is just non-comparable with Egypt. So we are pioneers in this. Actually, it's a big problem. Actually, it's an overwhelming number. Actually, I can consider it as an epidemic, which in turn now to an endemic. The studies try to explain why this medicalization shift. And we have some studies say that the female genital cuttings in Egypt has changed from an accepted custom to a political hot topic since 1994, at the time of international population conference that has been done successfully in Egypt. And during the peak of success of this conference that has invited all the world to Cairo, the CNN news featured a circumcision of a girl from Cairo by a barber. This was a shocking accident, actually, and this footage embarrassed the Egyptians and fueled a rush of all sectors with a health discourse against performing the female genital cutting with a barber. And the community perceived the message very well, and they shifted from doing this act, this ugly act actually, with the barbers and the dyers and etc., shifted to doctors. This was a very good example of how our wrong rushing discourse to the community can be influential and shifting the whole community to medicalization. From this point, medicalization stems from a misguided belief that the dangers of the female genital mutilation are medical rather than a fundamental violation of the girl's human rights. Actually, our battle is against female genital mutilation, not only the medicalization. Some studies tried to make a relation between the female, the overspread of medicalization and female genital mutilation, and the studies came out with two hypotheses. The first hypothesis said, and it is proved by some observatory and cross-sectional studies making association, that increased medicalization decrease female genital mutilation. Second hypothesis is the opposite. But actually, counterfactual data don't exist. And it is the results of the studies that making regression analysis, and it comes to that we have non-significant relation, either proving the first or the second hypothesis, and they are equal 0.25, coming out with the conclusion that it is non-significant. This studies was at the level of Egyptian studies, and I have only one study with regression analysis combined with governorate fixed effect using the Egyptian demographic surveys to 25 to 2014 came with this result. Increasing medicalization rate exists with decreasing prevalent rates inside Egypt, opposite to the other studies that has compared the pooled data from everywhere, like the Population Council 2018 study that came out that there is no significance at all, and no empirical research confirmed or refuted this claim. But actually, they give some data about that there is association between the countries that have increased criminalization and the speed of the decrease of female genital cutting in different communities. This figure actually represents the demographic data, the traditional demographic data that has been extracted from the studies about the criteria of the female genital cutting in the community. It is actually more prevalent in the rural communities with the most poor. It is more with the most poor families and the less educated. When I come to this figure, this represents the prevalence of medicalization. The studies told us that medicalization is more with the more educated families and with more socioeconomic standards. The SIPE report actually proved this, and this is the SIPE report, which is measuring the rate of medicalization with the wealth quantiles, and the poorest quantile was less medicalization, and high medicalization was found with the wealthiest quantile. I will come now to the third part of my presentation, which is tackling the issue of medicalization and the drivers of the doctors, why our doctors are making medicalization, and the recommendations from Dr. Mahmoud Fathallah and from his fantastic book about discussing different reproductive health issues versus human rights. It is for Dr. Mahmoud Fathallah and Rebecca Cook. They started their discussion through case-based studies. I will start with one of these studies, with case-based studies. A mother brings her 9-year-old daughter to the Dr. D requesting to be circumcised. The mother said, unless the doctor consent to perform the procedure, her mother-in-law will take the girl to the TBA, traditional birth attendants, or DAYA, to make more aggressive procedure. You are a doctor in your clinic, and this story is will be calling your ethics. What are you going to do? What is the action that you are going to take against this girl, considering the medical, ethical, legal, and human rights aspects of this case? Let us discuss and start from the ethical issues. Many doctors actually do the female genital cutting according to the ethical principle of non-maleficence, or doing no harm or less harm, and accepting to do a symbolic cut to the girl rather than let her go for a more aggressive cut by Daya or etc. Actually, Dr. Mahmoud studied this claim and said, if you are doing this symbolic cut, yes, you are going to save the individual, you are going to save this girl, but you will cause profound social injury. Any degree of cut considered as approval from you to perform this practice, to approve this practice, affecting woman body integrity and the dignity of human rights, because you will give the green light that doctors accepted to do this. You are the champion in your community. You are the change agent. Our struggle against the female genital cutting actually have to start from the doctors. We have to set for the law, for the role model in the community. But unfortunately, our doctors don't have this vision. They are not trained for the holistic thinking of the whole thing. Second, I will come to the law. Actually, we have a criminal law in Egypt since 28. This law has been issued after the tragedy of deaths of Budur in 27. Actually, our laws have been intensified across the years after death of different young girls while doing female genital mutilation with doctors. The press by that time, they announced that they are tragedy driving the reform of the law. Other titles, they said, these cases that changed the law, victims who sparked change. The law has been intensified to a felony in August 2016 and has been intensified and become harder again in 2021 after death of another girl. Actually, the UNICEF put criteria for the criminal laws to be aligned with the human rights, and this is the manual and the fact sheet about this regarding the criteria of an effective anti-female genital mutilation law, particularly from a human rights perspectives. Two important points has been added. Like first one is the consent to FGM is not valid at any age, and this is a very good point to be added to the criminal law, and it will prevent any valid defense against any individual case. Second is elimination of medical necessity, which has been applied actually to our law. This is unfortunately poor Budur that has been died in doctor clinic after overdose of anesthesia. Actually, we cannot incriminate the doctors alone. We have to incriminate the system who allowed the performance of surgical operations, which is non-medical, inside the without license inside the clinics, and who allowed the OBGYN doctor or the general practitioner to give anesthesia without audit, without supervision, without enforcement of the law. It is surprisingly enough that the first law was 28, and the first doctor that has been criminalized was 2015. So 7 years between the law and between the first application of the law. These are drivers of medicalization that has been collected from the different studies. Unfortunately, Egypt is cited as an example of medicalization challenge worldwide, but the different countries are cited as a model for norm change and grassroots empowerment. So what are the drivers of our doctors? Safety concern, as I explained before, with Dr. Mahmoud Fathallah case, doing no harm. Yes, majority of our doctors needs more training to reach this holistic approach and to be able to prevent and to refuse doing the operation. Second is cultural preservation. Don't forget that our doctors are part of this community and have the same tradition and have the same norms. So they need actually value clarification and training in how to perceive this procedure. Financial incentives. Yes, maybe. We have a lot of financial problems in our country. We have health system problems discussed elsewhere, and in the social media nowadays it is heavily discussed. Regulatory gap, as I mentioned, inconsistent enforcement on the anti-FGM legalization. We have a very strict and a very hard law, but at the level of application it is not working enough. We don't have a power for enforcement. Our doctors need gender sensitization, need value clarification, need sexuality and sexual health training, needs human rights explanation and training, need communication skills and advocacy, because they are the champions that are going to transmit the message to our people in the community and in grassroots organizations. They have to be learned about the side effects and the problems that might happen even if the doctor was the one who performed the operation. Our doctors has to be trained about the female genital anatomy. Many doctors doing the operation, and actually some studies says that doctors get their training about female genital mutilations, that it is not mentioned as a procedure in the medical box. They get their trainings from DAIA. They have to be trained about the female genital mutilation, genitalia anatomy. They have to learn about that the clitoris blood supply is a main artery and is coming directly from the internal pudendal artery, and the cut is not safe at all and may cause a profound bleeding till death. All these facts and all these things have been included in our training manual that has been prepared by me and a panel of experts that has been working in female genital mutilation abandonment across the history, and the task force responsible for the advocacy and mobilizing for the law from the Ministry of Health, from the National Population Council, from different NGOs, from UNICEF, and through discussions for more than a year, maybe 18 months, we have prepared these training manuals as TOT for the doctors, and the questions and answers for doctors as well. And these are the barcodes. If you photocopy, you can get both the training manuals, and these are the links you can get as well, the training manuals. Our training manual question and answer, we got our questions from the different from reviewing of different studies that studying the healthcare providers' attitudes and the discussions and the myths and different studies and different interviews and focus group discussions with doctors, and we collected all these aspects, and it has been put in question, and the answer, the evidence-based answer actually. So please photocopy the barcodes. Our training manual preparation, we adopted adult learning principles, we adopted value, beliefs, attitudes, and the value clarification, we adopted reflective practice and training needs assessment for the doctors. We adopted myths, heroes, and champions, how to create the champions in the community, and with concentration with advocacy principles. We adopted effective communication and trained the doctors how to be how to communicate with the community. Gender sensitization was added to our training manual, fostering leadership. This has been done within the political support and supportive legalizations, as I mentioned before, adopted by professional organizations, as I mentioned before. We used as well during the training innovative technology and the digital platform, and we give the TOT doctors the tools of PowerPoint presentations and the posters and etc. To be used, readily used for training of the grassroots organizations and other doctors, preparation, content, teaching, and application. We'll come now to the national effort, briefly to the national efforts that Egypt is adopting. UNICEF actually put some evidence-based lessons for intervention. Most of it we are using in Egypt, but except only one, which is the last one in red, the system strengthening our health system, strengthening and the capacity building of the health system, which needs actual reform. It doesn't devaluate our efforts, but we have to adopt the quality principle of practicing and keeping improving our practice and using the plan, do, check, act cycle and measure our success and our achievement towards our goals like sustainable development goals. And we have to accelerate our effort 10 times to reach zero level by after 5 years, by 2013. We have to do it again. And finally, towards a better future, there is an urgent need to shift from seasonal campaigns and sporadic training sessions, and to raising awareness to consistently systematic training, reform, and integrating messages to our community. We have to start not only from top down, not only through educating doctors, but only through widespread grassroots community changes, as it is done everywhere, and as it was done in Egypt actually for years, and led to successful changes, but it is not enough.
With the last few slides, very important
speed to our
links and
Thank
materials.
you so much.
Thank you very
and
much.
This is again the barcodes to be scanned.
I have
Thank
here,
you.
because we're running out of time, I have a comment. I want to take the opinion of you and your Professor Yasser. So the comment is, I would encourage the esteemed professors in this meeting to raise a concern at the level of the Ministry of Health regarding the issue of medicalization of performing FGM, and have the Ministry of Health to punish the medical professionals and retrieve their license in order to stop this shameful epidemic of FGM. Dr. Hala, so is it like...
Hala.
Yes.
Please, carry on.
Okay, so I'm so sorry. Can you repeat the question, please?
Okay, simply the question. raising a concern at the level of the Ministry of Health regarding the issue of medicalization of performing FGM, and have the Ministry of Health to punish the medical professionals and retrieve their license in order to stop this procedure.
Yes. It is in the law. Yes, there is punishment by the medical syndicate by withdrawal of the license of the doctor who are accused by performing female genital mutilation. The problem actually, Dr. Ram, that we have a problem with the audit process in health system. Like I cannot accuse the doctors alone. The doctors are not working in a vacuum. They are working in a health system. If this health system have no standards for audit and for follow-up of the doctors and what they are doing in their private clinics, so this is a big failure for the health system in general. There must be this follow-up. When there is a law as regards the medical doctors, the law has to include as well the health systems. Actually, the law include all the health institutions. The punished is not only the doctor, the families are punished as well, and the owner of the medical institution that the female genital cut has been done. But you know, everything is done in Egypt. We have the law, but we have no enforcement of the law. We have no power to enforce the law, especially the law is criminalizing the doctor and the family. So he is going to tell the authority that there is a case of female genital mutilation. If the girl had some complications, the family will be afraid to tell about, because they will be penalized as well. So I think our law has to be revisited. Especially in this area, in this time. So it's okay.
Thank you very much. Thank you very much, Dr. Hala. Dr. Yasser, the last question for you as a chair. We have here one question. Thank you. Please, do you carry out fellowship training in gyne-oncology for international doctors? He's asking about the gyne-oncology programs and courses.
Okay, so thank you for your question. Actually, we start to have a step forward to have these training programs by creating a new era of training program, which is I will share with you. And please, Mariam, put the slide of the courses we are going to conduct. One of them is related to colposcopy and oncology as well. So it's just a step forward towards some just hands-on training program. And I will be grateful for the one who asked this question, no, the other slide, this question, to send me or send you as well, Amr, or send to Jihan, our secretary, any thoughts regarding to what you want. By the way, we are not working alone. We are working for all of you, and whatever you suggest, we'll be more than happy to create and do as a community service and scientific service for Egypt and all over the world as well. So this is, as you see here, we will have gynecological oncology and colposcopic surgery. It will be between the 3rd and 5th May. This is our maybe second or the first course for us, and hands-on. You will be taught how to use colposcopy and principle of gynecology, gynecological oncology. You know, we are asking pioneers in this field to conduct this training. And if you are interested, please contact our secretary or contact me personally to put your name on the course. And I think you will have just basic principle of gynecological oncology and colposcopy. And there is another one as well for hysteroscopy, and the third one will use hysteroscopy and colposcopy in bleeding. So it's step forward, and waiting for your suggestion for more courses and more scientific program for that.
Thank you very much, Professor Yasser. I know it's very late. The last question, and that's it. Please ask Dr. Yasser for training for labiaplasty in Cairo. And that's the last one.
Okay, that's fine. By the way, when we discuss the situation of Egypt and African countries and the problem when we raised the issue of FGM, do you know why we raised this issue in adolescent gynecology? It's simply because the Royal College of Obs and Gynae back in England is very interested in this subject. So we used to do two things back in England and back in the Royal College to improve the scientific content and the scientific basis by creating guideline and discussing different issue all over the world and putting guideline which we are going to follow it. Not only that, but we start to shift long time ago, maybe 10 years ago or something like that, for community service in the countries that they are need to support. That's why the Royal College of Obs and Gynae adopt the idea of combating female genital mutilation all over the world, especially in Egypt. We have a special training program run by the Royal College, and we used to have certain training programs, as Hala mentioned, and she's one of the trainer. And I think Professor Hassan Shahata, president of the globe for the Royal College, used to come himself with the team from England to have this training in Egypt against medicalization, to have some sort of behavior change and acceptance of the idea of avoiding the FGM, and how can we convince doctor to avoid this problem. So as you see, the government and the Royal College hand in hand, and our society try by all means to spread this idea. So we are working in many levels. One level is the community service. The community try to raise the awareness of antagonizing female genital mutilation in schools, in universities, and in between lay peoples, using religious people and nurses and something like that to announce the problem with the FGM. This is community awareness. On the medical side, we are trying to conduct training programs to avoid this problem. And as well, on the law side, as Hala said, we are trying to push. However, as Hala said, the law want to be revisited. However, we have some sort of improvement, reduction of FGM, especially in the age of 14 or something, a little bit reduction, but it's a step forward. That's why. But to be honest, labioplasty, it's very difficult actually to conduct because the Royal College.
You've showed us many interesting cases in your presentation.
Yes. But anyway, I'll be more than happy to support you if you want that, but not through the Royal College, because the Royal College is not interesting in plastic for the time being, for plastic or cosmetic surgery at the moment. But anyway, you can contact me and I will support you as much as I can with the ethics of the Royal College to support everyone all over the world to have new era information, and whatever you are going to ask, I will be more than happy to support you.
Thank you very much, my dear Professor Yasser. And at the end, I would like to take a moment to thank all our distinguished speakers for this very exciting event. And now I'll hand over to my dear Professor Yasser for closing the webinar.
Okay, so thank you very much. I think we're approaching 300 something, 400 something like that, attendee from all over the world. So at the end of our webinar, which I'm so sorry to take longer time, because we raised a very important community-based problem as well, which you are going to face all over the world. So thank you very much to attend this meeting, and we are arranging again every month or every 2 months webinar, the same like that, as part of our activity. As we said, that we are very interested to have a very strong bond between Egyptian Representative Committee of the Royal College here and the International Representative Committee in the MENA region, in the in Arab region, and as well between England. And we used to have one from each country just to present something and to have a proper communication. Looking forward to hear from you. And again, let me to have to see the next slide, please, Mariam. Okay, no, the other one. Okay, let me to announce again that we will be more than happy to attend our conference in Egypt. It's the 13th annual conference, which will be held between the period between 23rd and 25th of June this year in luxury hotel, Triumph Luxury Hotel, where we are going to invite lots of consultants all over the world, and be sure that we are going to discuss new issue and new topics you will enjoy very much, and you will enjoy the wonderful weather at the time, because it's the best time if you want to visit Egypt, to do whatever you want, historical, Red Sea, diving, snorkeling, and so on, beside getting lots of information as well. Next slide, please. Don't forget that. Next slide, Mariam. 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 Amra, are you there? Okay, thank you very much. I think we come to the end, and thank you very much. Thank you.
Thank you, dear Dr. Yasser. Thank you very much.
Thank you very much. Okay, bye.
Bye.